I'll invite Dr. Ashvin Agarwal to talk on ICL surgery complications. Ashvin, please.
Hi, thank you very much. We'll be talking about phakic ICLs and its complications. Obviously, thank you, AIOS. And just in interest of time, we're going to do away with the questions till the end of this session because we have the next session as well. And we're running a little late on that. But coming to the topic of phakic ICL complications, I think my lens-based refractive, complete focus has been ICLs and predominantly star ICLs. So we'll not obviously have financial aid with LSI, but it has nothing to do with this talk. We're going to be talking specifically about star ICL in this scenario because I have experience only with that. And I'll just give you a little bit about ICLs. And the disclaimer is that 99 point whatever percentage you can think about do go well. So whatever we're discussing here is a very, very small fraction, but it's something that we all should know about in our daily practice if we are going to get into phakic ICLs at any point of time. So here you can see understand the ICL is extremely important. That's the orientation marks. So if you even rotate it 360 degrees, it's always going to be in the same orientation, bottom left, upper right. One of the hints that I can tell people, especially beginners who are going to start this, hold your steering wheel in that position, and that kind of becomes your norm when you're starting this procedure of phakic ICLs. So I think pearls and pitfalls which I want to get into in complications of phakic ICLs is going to be during investigation, what are the complications, during surgery, what you can face, and post-operatively what you can face, and how do you deal with it. So before we move into any of this, I think we first have to talk about the investigations that we do. These are the set of investigations that we do. The two most important ones being the pentacam and the ASOCT. The pentacam and ASOCT give me two big values. One is the AC depth, which I obviously have to measure both, and you have different techniques to measure them. But also the horizontal white to white, which is obviously used not just by us, but also the company guys who actually measure and size this ICL. And we'll come to the sizing in the post-operative segment, but that's an important part of the discussion, is the investigation and how this connects to the post-operative, because everything in ICL is diagnostic based. If your diagnosis is right, your ICL pretty much goes rather smoothly, except if you have an intraoperative issue, which I'll come to. In intraoperative issue, the first step is loading. Don't allow the loading to happen by someone else. Do the loading yourself. Ensure that there are no air bubbles in this viscoelastic injection in the cartridge. When you place the lens, make sure that you're concave down and convex up. Holding the ICL and pulling it all the way through is extremely important, but even more important is visualizing the orientation holes through that.
Outside the eye as a reference point.
So use that, I'm going to shut this off, but the basic idea is use the reference point of this cartridge lock which you're seeing over here. The cartridge lock is your only reference point when you're inside the eye. Use that to pivot left or right and make the holes face you at all points of time. The holes should face you at all points of time. That's the key idea here. So in case it's on the left, you actually turn the cartridge to the right and then inject. It avoids the complication of a flipped ICL. You will not have a flip in the ICL if your orientation holes are facing the microscope at all times. So just make sure, because it can twist while you're pulling through that hole. I'll just give you an example of this. What I do usually is under a topical anesthesia, of course, I do make my Wong incision in these scenarios because I want a closed tight-lipped wound. Once I have placed it, I'm already seeing my orientation holes, if you can see here on the left, bottom left. Once that is placed, I am putting the foot plates under the iris, and the foot plates can go under the iris. I'm using a simple wire rod system and to kind of pivot this into pivot the foot plates under the iris, and once it's in place, this is a non-toric, but you can always place a toric by rotating it. It's rather simple and easy to rotate. Once that is done, you irrigate the fluid. I use a Simcoe cannula. I know the rest of the world doesn't use it, but it's kind of quite controlled in these scenarios, especially when you want to go under the lens and so on. That really helps. if you have a flipped ICL, one technique that we talk about a lot, and I know it's a slightly cringy topic to talk about, but which is visco inversion. What happens in flipped ICL is you get a rotated one. It's not 360 degrees, it's a flipped one. So the orientation holes will not be in the bottom left, upper right, it will be in the exact opposite portfolios. This is a resident of ours who is actually intentionally flipping it without realizing the fact that he was doing this. And so when you come into a scenario like this, a bimanual visco insertion, so visco inversion technique is used. So you basically fill the chamber with viscoelastic and flip the ICL on one pole into the angle, and that kind of rotates the whole ICL across. And we've done at least more than 10 to 12 of these and had absolutely great results. We have this fear that the endothelium will get scraped. We have the fear that this, but honestly speaking, if you have a visco cannula in your hand and you're constantly filling that bag, there is a very less risk of this happening, and you can do away with damaged ICL, because while you're trying to pull out an ICL, there can be a little bit of damage, and you have to wait for 3 weeks more and then do the procedure. So those risks are aborted. Try this, and anyways you have that risk of damage and so on and so forth. So that's one way, and the other obvious method is explantation, but you have explantation requirements in any of these complications if you have. So explantation is rather simple. What I started to do a lot more is just make sure that the ICL is free, hold it at the optic-haptic junction, and that's directly in this angle, and just one cool pull out. It comes out through a same incision that you went in with. You don't need to extend the incision like in the other phakic lenses within India, but I think those are some of the huge advantages because of the polymer material that this is made up of, and that really lasts for even 20 years later. You can pull it off through the same incision size. So quite a few advantages here. I'm just showing you in these cases the cataract procedure as well, because the requirement over here was a cataract procedure for us to remove or explant, and the post-op day looks good. You don't have to really worry too much about that. The effect of the central flow is that you really reduce the risk of angle closure and reduce the risk of cataract formation. Sizing, these are the sizes that STAR sends, and you might want to note this because it's extremely important in sizing. If you have a large white to white, you please go horizontal. If you have a smaller white to white, you go snug fit. The thumb rule is keep it a snug fit always, rather than keeping it a loose fit, especially in the toric scenarios. Vaulting is extremely important, and for which sizing is key. The ideal vault you want to reach is 250 microns to 750 microns. The low vault is below 125 microns, and a high vault is 1000 microns or 1 millimeter or more. So this is the thumb rule which you want to use. The sizing, what should I do? What should the treatment be in any case? If you have a low vault, wait and watch if there are no symptoms. Guys, that's the general rule. Just wait and watch. If there are no symptoms of the patient, just wait and watch. It should be fine over a period of time. If you have symptoms, exchange the ICL, increase the size of the ICL to make it a snug fit. If you have a low vault, that means it's not sitting too high. If you have a low vault, you want to increase the size so that it fits snug and sits up. If you have a high vault, you want to reduce the size and make it fit little low. That's the ideology behind which you want to work with. So that's why the sizing is quite key and important to understand. Just go one size lower. Unfortunately, the sizes as I showed you is in 0.5 steps and not smaller. I wish they were smaller. We would have used that as well. Axis and rotation, use direct visualization. You can use a marker with a slit lamp, or in the new age digital marking system also it has a lot of impact. Other complications, you can have endophthalmitis, CME, damage to the ICL, as well as retinal damage and uveal retinal detachment and uvea and glaucoma issues. These are some of the complications of ICL. Obviously, to a larger length we can talk offline, but right now, thank you very much for this talk.
Thank you, Ashvin. No doubt ICL is a very successful and rewarding surgery. Sometimes it really gives us amazing results.